Good afternoon, everybody. I'm really thankful to Dr. Khanna inviting me to talk on access site closure. I'll begin my talk with various methods available for access site hemostasis. It can be broadly divided into manual compression, the mechanical compression, and then we have multiple vascular closure devices. So we all know manual compression has a very good track record of last 60 years. It's a gold standard. No extra cost is involved, no technology, nothing is left inside at the arteriotomy sort. The downside is definitely there is increased time to hemostasis, ambulation, discomfort to the patient. It requires extra manpower if you're doing in a holding area. May slow down the throughput of the recovery area, and nowadays we have obese patients. Most of our patients are on anticoagulation, antiplatelets, and then always there is a risk of leaks, ischemia, DVT. Coming to the mechanical compression, I don't see any additional advantage. It can save an extra pair of hands, but again needs a close monitoring. There is a bit learning curve, and rest of the downsides are the same as with manual compression. Coming to the vascular closure devices, we have too many vascular closure devices available in the market. Broadly, they can be classified as active approximators, the passive approximators, and some with novel technologies. The active approximators, what they do is they physically close the arteriotomy hole using sutures, clips, staple. The passive ones are those in which sealant or a gel is used to plug the track, and then it needs adjuvant manual compression for a couple minutes. And then the novel devices in which nothing is left inside the track or intravascular or extravascular, and that aids in manual compression. So coming to the active approximators, they are further divided depending on their mechanism of action. We have collagen foot plate device, that's Angiosail. Suture-based devices are Perclose, ProStar, Superstitch, and then clip staple-based devices are StarClose. Coming to the Angiosail, I think still most widely used vascular closure device comes in 6 and 8 French size. Basically what it has is 3 components. The foot plate, and then there's a collagen and the suture. Everything dissolves in 60 to 90 days. The IFU says the vessel size should be at least 5 mm diameter, and it's recommended for CFA retrograde puncture. Downsides of any vascular closure device is the cost, the learning curve. It leaves a foreign material inside, so there's a chance of infection. Being something is left intravascular, there's always a chance of embolization. The upside is comfort, early ambulation, can be utilized in daycare procedures in a high volume setup. So I'll just quickly show the videos. So that's the sheet which comes with the Angiosail. The existing procedural sheet is taken out. The Angiosail sheet goes in. There is a hole right here. So the blood comes back, it bleeds. You have to take out the dilator, hold it with your left hand. The Angiosail device consisting of the foot plate goes in. Once you click it, the foot plate is deployed. The second click fixes it. Then the whole assembly is pulled out. And then there is a rail mechanism which pushes the collagen plug to seal the arteriotomy site. And then the suture is cut. Coming to the suture-based devices, we have most popular among those is like the Perclose ProGlide, recommended for 5 and 8 French procedural sheets. It's a surgical knot. Again, we have same pros and cons as with other vascular closure devices. This is how it acts. Again, the procedural sheath is taken out. The perclose goes in. There is a hole right here. So once that is at the access site, the wire is taken out. It goes in. Here you can see the bleed back. That's step one. It deploys the foot plate. Step two, the needles are pushed in. The sutures get anchored. And then step three, you pull it out. The thread needs to be, yeah, you cut it here. There's a scissor right here. The foot plate is collapsed. You can pull the device out. You have the thread. The one with the white mark locks the knot, so don't pull that. The other one is pulled. It has a rail mechanism, so the knot goes down, and then you have a plunger. You can push the knot inside, and finally you can cut it. Off-label use of perclose, you can use it for larger size sheets at different, if it's placed in different angles, like 2 o'clock, 10 o'clock position, 4 o'clock, and then a third device can also be placed if the sheath is bigger. Similarly, there is a ProStar. It's also a suture-mediated device with 2 sutures. It has like a ProGlide, similar mechanism, but I think it needs a more learning curve. It's meant for 10 French size sheets. Once it goes in, same mechanism, bleeds back, pull the plunger. You have 4 needles. They're pulled one by one. The needles are cut apart. Then there's they have a color coding. You have white and green sutures. And it does not come with a preformed knot like the ProGlide. So you have to tie the knot in the similar fashion, pull the rail, the knot goes in, and finally you have a surgical knot at the arteriotomy. So coming to the clip-based device, StarClose, kind of most popular among them. IFU is for 5 and 6 French. It has a nitinol clip. You can see here, so nothing is left intravascularly. This is how it is placed over the arteriotomy. Additional point to note is it should not be placed in those patients who are allergic to nickel and titanium. May cause some artifacts on CT and MRI. So it comes with its own sheath. The procedural sheath is taken out. The sheath is placed in. The device locks right here. Then they have made a spatial angle so that you can keep your hand in 45 degree. Pull it back. When you push the plunger, this is a sharp thing which dissects your needle right here. So the device is like tilted in a 45 degree. This click, that's it. Now coming to passive approximators, I think the device available here is an ExoSeal, and there is Minx and Fat Seal. Nothing is left intravascularly in these devices. It has a polyglycolic acid plug. IFU says it dissolves completely in 60 to 90 days. It can be placed through the same sheet, so you don't have to take the sheet out. And as with any other vascular closure device, avoid at calcified plaques in diameters less than 5 mm and avoid in antigrade sticks. So important thing is there is a marker right here, and then there is a window. This is the procedural sheath. It comes in 3 sizes, 5, 6, and 7. This goes in up to the marker. The sheath is pulled back. As the sheath is pulled, this gets naked. And then there is a bleed back. So once you're pulling it out, a ring is deployed, which acts like an anchor when you're pulling the entire system out. So right here, it hooks the arteriotomy. And slowly when you pull, you can see the change in the marker here. That means you're at the appropriate position, you're extravascular, and then you just push this button and the plug is deployed. There's another device with the same mechanism, Minx. All it has is a balloon instead of a ring. A few additional steps. You have to inflate the balloon. Then it uses the same sheath. All you need to do is push the collagen, which is like a PEG material here, polyethylene glycol. They claim it dissolves in 30 days, and similar mechanism like Exoseal. Everything is extra action. And the other devices which leave nothing, among them popular is Boomerang, and then the latest versions are Catalyst 2 and 3. It's nothing but a disc. The advantage is nothing is left inside. The Boomerang effect is described as the arteriotomy tract reduces once you put this device in, and this is mainly to help the manual compression. So this is how it goes in. Deploy the disc. The sheath is pulled out. Right, it seals the arteriotomy. And then you can place a ring or something here. The patient can be sent to the holding area. And then with Catalyst 2 and 3, I think the 3 has a protamine coating. So in those patients which are heparinized, it acts well. And then you have adjuvant hemostatic patch, which can be placed at the arteriotomy, which helps in accelerating the clotting and helps the manual compression. One thing I would like to say is, before placing a vascular closure device, as one of our expert panel told, like, try to take your puncture with ultrasound guided if you have a facility. I always do a check angiogram once I start my procedure and at the end of the procedure, ensure the size of the lumen, any atherosclerotic calcification, and then if you're deploying a vascular closure device, please follow aseptic technique, re-globe, re-prep, if needed, give an antibiotic. So final verdict is always plan closure before you take access. Decision on using manual closure or vascular closure device is complex and it depends on many factors. I'll say go for vascular closure device when risks are reasonable. Many studies have been done comparing manual compression with other vascular closure devices, but the data are still insufficient to differentiate between which vascular closure device is best. I'll say physician should use the one he is best comfortable with. Thank you.
Do we have any questions from the floor? You can stay on.
What kind of precautions one should take before using these external closing devices?
Yeah.
Like whether if the patient is having very high blood pressure, or if his ACT is very high after the procedure,
right,
then one should use this.
See, these closure devices are meant in those situations. If you need to keep the ACT high, if you have placed a stent, if patient needs to be heparinized, I think you can go for active approximators. So they physically close the device. Definitely blood pressure has to be brought down for even for a manual closure. If it's too high, you need to bring it down.
What he's probably wanting to ask is that what ACT you will accept, the maximum ACT for closure device?
For active closure, I think I'm comfortable with ACTs of even 200.
Yes. 200, but not 250.
I mean, there's no such IFU, like, but definitely if it can be brought down, then you should.
We have been using Exoseal device in
Right, right.
We were successfully closing in few cases where the ACT was very high, around 300, and when the blood pressure was very high.
Yeah,
180 and above.
I completely agree because it's a passive approximator. That's what I'm telling. It just plugs the track. So in those cases, I would love to use a ProGlide or an Angioseal and not an Exoseal.
And what about whether these devices are available in 7-point size?
Yes, the Exoseal is available.
Sorry for the interruption, Mr. Chairman. We have totally run out of time for this presentation. With your permission, we have to move on to the last presentation. Thank you, Dr. Shirin. We have Dr. Michelle Henry. If you could please join us for next 7 minutes to speak on how to establish ideal access for intervention in peripheral vascular disease.